All right, so I'm going to go ahead and start it. Welcome today to the cardiology grand rounds, and for sharing the details of the CME crediting and other information. Please go ahead and text 17009 to 888-816-4893 as an SMS message. You can do that now. 17009 to 888-816-4893 for getting your CME credit for the session. And for the maintenance of certification points, please complete the step 1. And this link, which will also come back into the chat box, would need a room code future35. And this will lead you to the Q&A sessions. If you answer them correctly, you get the ABIM credit for the maintenance of certificate points. So these two steps will be again displayed back into the session. So please make avail of this opportunity. So now it's my distinct privilege and pleasure to introduce our speaker for today's grand round, Dr. Jules Gordon. So Dr. Jules Gordon is a name to reckon with in the field of echocardiography. In fact, in 2019, the American Society of Echocardiography honored him by having a name lectureship, the Gordon Lectureship. And he has been a strong force and very instrumental to the promotion of echocardiography in not only just here, but also through his work in ACC, AHA, and global work. He has been promoting the standardization of echocardiography elsewhere also. So it's a great pleasure to have you, Jules, and we are delighted, and we are also honored to know that we have someone so close we can always reference and refer to you. In fact, I've had the distinct privilege of knowing him for the last about 10 years, ever since I've seen him, not only in ASC, but also closely interacted with him. In 2014 and 15, he was a technology enthusiast and joined a task force where he helped us to collaborate and investigate what the new areas of echocardiography are going to look like. And ever since then, he has been a close acquaintance. In fact, before I came here and joined here, he was perhaps one of the earliest person I called to understand what was the topology of echocardiography and cardiology in New Brunswick. And he was also one of my reviewers who wrote a letter of recommendation to get me to this position. Dr. Gordon did his internship and residency in internal medicine from University of Michigan affiliated hospital, Ann Arbor, Michigan, and subsequently his fellowship in cardiology from Georgetown University affiliated hospitals in Washington. He had his first faculty appointment at Northwestern University in Chicago in 1977, and subsequently moved to University of California, Irvine in 1979, where he rose and became the chief of the division of cardiology. He subsequently moved and came over here in 2008, and he has been a professor of medicine in the Department of Internal Medicine, and at the present is the director of the Division of Cardiology at Rutgers University, New Jersey Medical School. He has been influential in several international and national societies, American College of Cardiology, American Heart Association, and most importantly, American Society of Echocardiography. In fact, he was the president for the American Society of Echocardiography between June 1993 and June 1995. He has several awards, and it will be too many for me to be able to cover this during this brief introduction. But most importantly, he was the coveted Adler Lecturer for the American Society of Echocardiography annual scientific session in June 1995. And as you would know, this is one of the most endowed and coveted lectures in the American Society of Echocardiography. With regards to his contributions to the field of echocardiography, there are some areas where he has had monumental contribution. Number one, the ethnic and gender age differences in left ventricular mass and deformation. He has contributed enormously into the epidemiologic studies and clinical trials in cardiology, particularly in the field of congestive heart failure, detection of cardiac abnormalities, and also to national clinical guidelines. In fact, he was a recipient of the first NIH NHLBI contract in 1988 as the principal investigator for an echocardiography core laboratory for a multicenter study on risk factor for cardiovascular disease. And he has contributed to several epidemiologic studies at the National Institute of Health. He has over 300 peer-reviewed publications, invited editorials and textbook chapters. And most importantly, he's very close to us, and he's contributing to the growth of echocardiography and maintenance of what is required is the quality of echocardiography, which is very important. And we were just talking about how we can attain that given so many different areas that you have to attend to. But I'm sure that he has something in store for us. He's going to take us through the past, present, and future of echocardiography. So Jules, thank you very much for being here today. And we are so delighted you took the invitation to be part of this.
Gupta, I'm blown away by your introduction. And I really feel the same way about you in terms of your contributions. So let's see what we can learn today. So I've titled this Echo Past President, Pitfalls, and Promise. And let's see, I'm attempting to advance the slide here. Let's see. Dr. Yanamala, I'm just wondering.
You can use the arrow buttons on your keyboard, Dr. Garden.
Yeah, that's what I'm, okay, now it's working. Okay, all right. So what I'd like to do is to highlight some key areas in echo in terms of accomplishments, challenges, and potential directions. But I'm going to focus on examples rather than present an exhaustive survey of conditions studied by echo and basic clinical and population studies. And, share some insights and perspectives gained as an observer in the field for a relatively long time. Now, I think it's important to just start with a few echo images. This is a normal echo, 2D on the top, parasternal long axis, short axis view, and derived M mode echo. And this is a 3D echo that, again, it has certain advantages. We're not going to talk too much about 3D today, but it does have advantages of no geometrical assumptions, generally unaffected by foreshortening, although we don't really display the apex so well here. And it's more accurate and reproducible than 2D echo, but it has lower temporal resolution than 2D M mode. There's less published data on normal values. Like 2D and M mode echo, it's image quality dependent, and really importantly, not enough and not universally recorded. Just a slide on the Doppler principle. And I think it's helpful to sort of review the fact that we're using the same ultrasound, that we are reflecting it off red cells in the heart chambers and vessels, and that, again, we're comparing the emitted ultrasound to the received ultrasound. If there's no change in the frequency or wavelength, that goes along with a zero flow. If the cells are moving towards a transducer, again, the frequency increases, the wavelength decreases. And if the cells are moving away, the frequency decreases, the wavelength increases. And so we can figure out velocities of cells based on the change in the shift in frequency between the emitted and received ultrasound, the velocity times the velocity of ultrasound in tissues, which is about 1,540 meters per second, over twice the fundamental frequency sent out. And the cosine of theta, of course, is very important. So we want to get as parallel to flow as possible. Now, as Dr. Sengupta said, that echo has been quite useful in epidemiologic studies and clinical trials. I'm only going to touch on some of the use in epidemiology in valvular disease, and also, if I have time, a little bit about carotid IMT. But note that there are a lot of applications. And I thought we would just start with a review of some of the issues and also findings in terms of the left ventricle, whether it's mass, septum, posterior wall, conditions such as HCM and basal septal hypertrophy, LV systolic function, and diastolic function. I thought I would start on the epidemiology front with showing a classic slide from the Framingham Heart Study that looked at 4-year age-adjusted incidence of cardiovascular disease versus LV mass by echo, the 2D directed M mode, and they adjusted their mass for height. And notice that as you get into the highest quartile, both in women and in men, the age-adjusted incidence of CV disease is much higher than in the lower panel. I've had the opportunity, as Dr. Sengupta mentioned, to serve as the core, the PI for the core echo lab for some NIH studies, one being the cardiovascular health studies, which was an NHLBI-sponsored study of risk factors for incident heart disease and stroke over 6 to 7 years in 4,800 subjects greater than 65 years of age. And again, we're seeing something similar here. The adjusted hazards ratio for incident CHD and CHF by quartile of echo LV mass or diastolic posterior wall thickness. And again, as you get into the highest quartiles of LV mass or wall thickness, the incidence of heart failure and to a lesser extent coronary disease increases. Now, the guidelines from the American Society of Echo recommend, if you're going to use what we call the linear method, whether it's MO directly or 2D directed MO to measure the septum, that left ventricular internal dimension, and the posterior wall, we can use this cube formula to estimate left ventricular mass, which basically includes the entirety of the septum, internal dimension, and diastole and posterior wall cubed minus the internal dimension cubed plus some adjustment factors here. And again, there's some advantages and disadvantages. It tends to be reproducible, relatively high temporal resolution, and a wealth of published data. And it also facilitates orientation perpendicular to the ventricular long axis if you use the 2D to orient you. But nonetheless, we don't see the axis in the third plane, and so the beam orientation can be off axis. And again, this is a single dimension, so it's representative only in normally shaped ventricles. And I'll show you where this may become a problem. So these are normal values published by the ASC in 2015 in the salmon-colored row here. And notice the ventricular septal thickness range that they're giving, mean plus 2 standard deviations, is 0.6 to 0.10, and same for the posterior wall thickness. Now, I've recently been asked to be involved in a study that has also a large population study, and to be involved in reviewing the data. And notice that the upper limit of normal, quote, or 2 standard deviations for the septum is 1.6 and posterior wall 1.2. So obviously there's quite a discrepancy. And the question is, why is this? And one reason might be, and Dr. Nat Pandian and I looked at this years ago with Walter Henry, especially as you get older, you tend to get this basal septal hypertrophy. Again, the question is what to do with it. Now, if you use the ASE standards for measuring it sort of at the level of the mitral leaflet tips, what will happen is you will underestimate the LV dimension, say this dimension compared to this dimension, and also the volume. And you may overestimate LV mass if you measure it here at the bump. I personally, when I see these clinically, I measure the dimension down here, the septal thickness about here, and then I report that there's isolated ventricular basal septal thickness, and we have a code for that. Now, again, just moving briefly on to hypertrophic cardiomyopathy, of course, you can also see asymmetric septal hypertrophy. And systolic anterior motion, and an LV outflow tract gradient, and also very commonly mitral regurgitation. And years ago, again, I was involved in a study as the PI for something called coronary artery risk developments in young adults, where we studied individuals ages 23 to 35 at the time of their initial echo. And one advantage of this study is that half of the cohort was Black, half white, half men, and half young women. And we found a prevalence of hypertrophic cardiomyopathy of about basically 1 in 500 or 0.17%. The way this played out is our readers read all these studies, and I got a call from Barry Marin, who, as you might know, is one of the world experts in echo, and he said, because I met him when I was a fellow, Jules, you know, I know you're working with the Cardia study, and we'd like to find out what the echo prevalence is of HCM. And did you try to record that, at least the presence or absence? I said, yes. He said, well, how about if I come out and blindly read 1,000 of those 4,000 studies? And if I agree with you, we'll publish the study. Well, of course, with great trepidation, I said, of course, Barry, come on out and I'll show you Laguna Beach. But luckily, Barry agreed with our readings, and that's how at least this number was established. Now, of course, echo is not the only story in hypertrophic cardiomyopathy. The classic teaching was that familial HCM occurred as an autosomal dominant of inherited sarcomeric protein mutations 50% of the time. But there are certain limitations of this single gene sarcomere mutation hypothesis. First of all, these mutations are absent in 70% of sporadic cases and 40% of familial cases of HCM. And carriers of this purported HCM gene mutations may not develop the disease, and also some features associated with HCM, for example, regional LVH and myocardial fibrosis, abnormal elongated mitral valve leaflets, abnormal intramural coronary arterioles, are not associated with sarcomere, with cardiomyopathy sarcomere proteins. So again, this is just, echo is very important, but we have to remember that when we're evaluating people for this condition and their families. Now, another, I would say, interesting finding from this coronary artery risk development in young adults was that all but one of the 27 young adults who developed heart failure before the age of 50 were Black. And 75% of those who developed heart failure, not surprisingly, had hypertension before the age of 40, and 27% had depressed LV systolic function already at the ages of 23 to 35. And if we detected systolic dysfunction by echo, it was associated with heart failure 10 years later with a huge hazards ratio of 37 and borderline systolic function hazards ratio of 3.5. And other independent predictors of heart failure in this cohort included diastolic blood pressure, higher BMI, lower LDL, and kidney disease that developed. Now, I also had the opportunity years ago when I was at UC Irvine to spend a year in a cardiac molecular biology lab with Leslie Leinwan at Einstein. And this was a lab that worked on myosin heavy chain, and I'd written an NIH NSRA grant with her to study different mutations in the myosin heavy chain, looking for cardiomyopathy. But as I got there, I realized that, you know, they also had other models of heart failure, and they were doing aortic constriction, and they needed a way to non-invasively image these mice. So what we see here is an echo from a mice that had the MYF5 mutation. And again, the fractional shortening was 24%. And this was a littermate who had a normal ejection or fractional shortening of 58%. And when we plotted our data for echo LV mass in these mice on the vertical axis and actual LV mass, again, the black dots are the wild type mice. The triangular are those who had aortic constriction. And the two of them also, the black ones had the c-MYC gene that is a myosin gene as well. And again, they all fell on a nice line together, but notice that the echo measurements underestimated the actual LV mass, but again, with a regression equation, could estimate them. Now, I'd like to move on to another, what I find interesting area of ventricular function, and that is strain. And again, strain is myocardial deformation, shortening or lengthening, occurring at a specific time in the cardiac cycle. And the idea is that we're really looking, and this is exaggerated just to show the concept, of the shortening in a particular segment of the myocardium from diastole to systole. Now, strain measurements are displayed as negative numbers, and this is a simple example where L sub O is end diastole, and L sub 1 is systole, which is shorter. And so, and then you do the ratio over the diastolic length. And here in this example, you get -2/4 or -50%. And the reason that people are interested, among other things in this, is it turns out sometimes it is more sensitive than ejection fraction, but it also does not have the dependence on rotation or translation of the entire myocardium. In effect, you're summing individual measures of LV function and to give a global, if you want, or a regional LV function. So again, this is a depiction of a global systolic strain, the peak value here being -23.7%, which is normal. And again, you can display each of these points individually to see if there's, if you will, a wall motion abnormality. Advantages are that it tends to be angle independent. It's of established prognostic value in conditions such as cancer, patients receiving chemo or radiation therapy, aortic stenosis, LV diastolic dysfunction. Again, there are many additional applications. Limitations that we should keep in mind is that this technology is vendor dependent. So you want to use the same machine, the same online or offline software to follow a patient. And it's also technique dependent. You want to make sure that you don't have misregistration or some of the other technical issues. Now, I think a field that is really becoming hot now is the area of using the same strain concept for left atrial strain. And again, what investigators are looking at are here, for example, first the LA reservoir strain, and you can see this in the QRS complex, the T and the P waves below here on the EKG. And then that's followed by left atrial conduit strain, okay? And then finally by left atrial contractile strain. And just, I'll show a couple examples of where this has recently been shown to be of use, and there are many others. In this case, in a series of 291 patients with cryptogenic stroke, a multivariable hazards model showed that LA reservoir strain and contractile strain were independent predictors of recurrent ischemic stroke, or TIA. And similarly, in another study that is just published, I believe, online now, in aortic stenosis, these workers, Tan et al., looked at 173 asymptomatic or minimally symptomatic patients with moderate to severe AS and LV ejection fraction greater than 50%. And they found, among other things, that LA conduit strain less than 6% demonstrated a specificity of 95% and a positive predictive value of 82% for the composite primary outcome of all-cause mortality, heart failure, hospitalization, progression to NYHA class 3 or 4, acute coronary syndrome, or syncope. And of interest, the prognostic value of these LA strain variables was independent of clinical variables and NT-proBNP. So I think there's definitely value added in this measure, and we'll only hear more about this. Now, I want to spend a couple minutes on LV diastolic function. And to the left of your slide, and I want to highlight that this is where the modified Bernoulli equation, which showed that the difference in pressure between two chambers, for example, the left ventricle and the left atrial pressures here is roughly equal to 4 times the velocity squared in our pulse Doppler recording, or if this were a continuous Doppler recording. Notice in the normal pattern, notice where the LV relaxation drops below the LA pressure, we get this E wave, and later in diastole, atrial contraction, where the atrial pressure exceeds the LV pressure, and we get an A wave. Now, in impaired relaxation, but with normal left atrial pressure, we tend to get an increased isovolumic relaxation time, and we also get an increased deceleration time. But importantly, notice the difference between these two curves is less, and the E wave is lower, but in later diastole, the A wave is taller. Now, again, anything that will raise the pressure early in diastole, like restrictive filling pattern, but also mitral regurgitation, will lead to increased LA pressure and an increased E wave, and sometimes a lower A wave. And this is from some early diagrams demonstrating these things. This is called pseudo-normal here, but it could also be mitral regurg plus impaired relaxation. And this was also called restrictive, although that may not always be the case. Now, the American Society of Echo came out with guidelines, and this is just one table, and I'll go through it a little bit more in detail than I've done other things, but this is for estimating LV filling pressures and LV diastolic function grade in patients with decreased LV ejection fraction and myocardial disease. Now, notice the first thing that they focus on is the mitral inflow, the E to A ratio, velocity ratios. And what they say here is that if that's less than 0.8 and the E wave is less than 50 centimeters per second, then if you do have some myocardial disease, this is going to be normal LA pressure and grade 1 diastolic dysfunction. Now, if that E to A ratio of mitral inflow is greater than or equal to 2, then this qualifies as someone showing increased left atrial pressure and grade 3 diastolic dysfunction. The real problem comes in when you're in this intermediate zone for the E to A, but between 0.8 and 2, or an EA ratio less than 0.8 and an E wave greater than 50 centimeters per second. And then the ACE criteria specify that you look at 3 other criteria, including the transmitral E to E prime. Now, the E prime is shown here. This is a tissue Doppler recording. We do that at the mitral annulus, both in the lateral and medial sides. And this is really sort of in the muscle, if you will, or at the annulus. If that E to E prime is greater than 14, or the tricuspid regurg velocity is greater than 2.8 meters per second, or the LA volume index is greater than 34 mils per meter squared, then if 2 or 3 of these 3 are negative, then you have this grade 1. If 2 of 3 are positive, then you're in grade 2 diastolic dysfunction. But if only 2 criteria are available, if 1 is positive and 1 is negative, then you really can't determine the LA pressure and the diastolic function grade. And this would be indeterminate. And likewise, there are other causes of indeterminate diastolic function, such as if you have diastolic dysfunction with a lot of mitral regurgitation. So this is where workers have tried to use machine learning. And I'll just show a couple examples in this case. And this is from work of Zhang and Associates. Again, they point out, of course, that the mechanism of LV diastolic dysfunction may be complex. And they used a number of machine learning models shown here to train and classify studies using a training set of over 23,000 studies and a validation set of almost 5,800 studies, according to the American Society of Echo and the European guidelines for LV diastolic function categories. And what they found was that a machine learning derived continuous diastolic function score could classify patients as having normal diastolic function with a score of 1, or mild or moderate or severe diastolic function as the score decreased. And a score of 0.91 predicted abnormal diastolic function with an amazing area under the curve of 0.99, and a score of less than 0.65 predicted an elevated LV filling pressure with an area under the curve of 0.99. And this ML derived score correlated well with the most recent ASE European guideline grading for LV diastolic function. So what's the problem? Well, in this study, patients with indeterminate LV function under current criteria were excluded. Well, there's a big number that we'll talk about that fall into that indeterminate range. So there have been other attempts to characterize diastolic function. Here's one of them, or actually a couple of workers have worked on this. My question was, could artificial intelligence methods help further characterize LV diastolic function in patients who currently have indeterminate diastolic function due to missing Doppler components or confounding conditions such as severe MR? And in these studies, an AI-enabled platform was reportedly shown to have 88% sensitivity, 83% specificity for the detection of heart failure with preserved LVEF. Now, my further question was, could AI leverage clinical data, including outcome studies, to better characterize LV diastolic dysfunction? So this is a recent study from Dr. Pellica's group, where they used unsupervised machine learning to assess LV diastolic function and risk stratify. And again, they studied nearly 25,000 adults undergoing transthoracic echo at Mayo in 2015. And they used the 9 standard LV diastolic function echo variables, similar to the ones I showed that were in use by the American Society of Echo algorithm. And with this machine learning algorithm, identified 3 echo variable clusters corresponding to normal LV diastolic function, impaired relaxation, and increased LV filling pressure. And interestingly, they were able to look at 3-year cumulative mortality and notice the increase as you went from normal to impaired relaxation to increased LV filling pressure from 12% to 20% to 33% in these clusters, which actually outperformed the guideline-based grades for prognostication. And importantly, unlike the previous AI algorithms, this approach was able to reclassify all over 10,000 patients initially classified as having indeterminate diastolic function. Now, let me turn for a few minutes to valvular regurgitation. And we know that there are a number of ways to classify mitral regurg by echo Doppler. I'm showing 3 of them here, and we'll go over them very briefly to make a few points. So this is one of the early methods from the lab of Dr. Nanda, where basically you planimeter the area of the jet and display it as a ratio to the LA area. And again, if it was under 20%, that goes along with 1+ MR, 20 to 40, 2+, and greater than 40, 3+. Now, of course, if you have a jet that hits a wall, you're not displaying the full jet, that could be a problem. Another method that has been suggested is what's called the vena contracta method. And you can see here that as flow goes through an orifice, there is a narrowing here, the vena contracta. And this shows that the vena contracta width correlates with regurgitant volume. And again, if it's maybe 0.6 or 0.7 centimeters or more, that tends to go along with higher regurgitant volumes. But again, 3D echo has demonstrated that, not surprisingly, the vena contracta orifice is not circular or constant throughout the cardiac cycle. Another way that has been used, and we were involved in this, and we were able to get a patent on it, was what's called the proximal isovelocity surface area method, or the PISA method. And it takes advantage of the fact that as flow approaches a narrowed orifice, the velocities increase, and that because you can manipulate the colored Doppler reference bar, you can sort of set what this velocity is, and that you can multiply that velocity times the surface area to determine volume flow rate in cc's per second. So again, you measure the PISA again, and we'll talk about the assumptions that you have to make, and you get 2 pi r squared. You multiply it by the velocity here, centimeters per second. That gives you maximum volume flow rate. And then in order to get regurgitant stroke volume, you take that and then you multiply it by the continuous wave jet, the time velocity integral, the area under this curve, which is in centimeters, divided by the peak velocity which is centimeters per second, and that turns out to be cubic centimeters. Now, again, there are sources of error in this, including if you have an eccentric or truncated PISA due to wall impingement, and again, may certainly be non-hemispheric geometry of proximal flow convergence. You may imprecisely identify the regurgitant orifice, and also dynamic changes of PISA throughout systole. And we'll get back to that in a minute. Another way that we use is we look for systolic flow reversal in the pulmonary vein. That speaks to severity. And also in selected cases, we use a time velocity integral method to calculate regurgitant volume and effective regurgitant orifice area. And this is just, if you will, a drawing to show that. So for mitral regurgitation, we figure out the forward flow or stroke volume by measuring the diameter of the annulus here in the LV outflow tract and multiplying it by the area under the flow velocity curve. And the total stroke volume is the area of the mitral annulus, which is also pi diametered over 2 squared, times the diastolic flow velocity here. Now, there was a relatively recent paper that called out discrepancies that had been observed between 2 echo methods, which we'll talk about in a minute, the PISA method and the volumetric VTI method that I just showed you, and CMR methods for quantitating primary mitral regurgitation. They studied 188 patients with moderate mitral regurg using these 2 echo techniques and also the volumetric CMR technique. And the results showed that the MR PISA regurgitant volume technique only correlated weakly with the CMR regurgitant volume, and also not so well with the TTE volume technique. And whereas the CMR regurgitant volume and the TTE velocity time integral technique were related to LV end diastolic volume, the PISA regurgitant volume was unrelated to LV end diastolic volume. And so the author suggested basically we shouldn't be using the PISA technique. And these just summarize the techniques they used. This was the PISA technique that we've outlined before, and the MR technique where they subtracted the LV end systolic volume from the diastolic volume. That gave you the total stroke volume. And then they got this curve to determine the forward flow of the aortic valve. Now, limitations, though, of this study included that the fact that only patients with mitral valve prolapse were included. And the study, therefore, included patients with relatively curvilinear rather than flat mitral valve geometry. And again, PISA, when you do it this way in the 2-dimensional mode, it assumes a hemispherical shape. Now, initial PISA models demonstrated clearly, certainly in our lab and others, that PISA is a hemi-ellipse, generally being hemispherical under selected conditions. And a 3D PISA model is more accurate and comparable to the CMR model. And this is a slide lent to me years ago by Manny Vannin showing his work modeling 3D PISA. Another problem with the ALTA study is they excluded patients with mild aortic stenosis. And a recognized limitation of this transthoracic echo VTI regurgitant volume method involves the difficulty in accurately measuring LV outflow tract diameter in folks with a lot of calcium. And so you have a problem calculating the forward flow. So as an example, if your diameter in the aortic annulus area is 2 centimeters rather than 2.2 centimeters, you can have a 20% difference in forward stroke volume. So again, we need more than one method for calculating regurgitant volume. Now, again, there is advantages and disadvantages of cardiac MR. These show some of them on this slide. It's 3-dimensional, high spatial and temporal resolution, no ionizing radiation, multiple imaging techniques in a single system. But it can be contraindicated with some medical implants. Acquisition time can be lengthy. EKG can be distorted by the magnetic field. It requires ECG and respiratory gating, and some patients are just claustrophobic. So what I'm hopeful that we'll see more of, and certainly Dr. Sengupta and Yanamala and the team there are doing yeoman work in this regard, is to look at techniques like echo, given their advantages and disadvantages, and CMR, take the clinical data, demographics, risk factors, and then apply artificial intelligence to improve diagnosis, therapy, and prognostication. Now, we talked about MR, just a couple of slides on aortic regurgitation. A similar method used to determine aortic regurgitation. One of them is the jet height here versus the LV outflow tract width. And this almost occupies the LV outflow tract width. I just want to point out, we have to be aware of the pinhole effect. So I've seen many people make errors where it starts off with a small orifice and then spreads out. People measure too distal in the jet and then overestimate the aortic regurgitation. Other ways of doing this are looking for reverse diastolic flow, holodiastolic. This is in the aorta, in the thoracic aorta. We've shown this also works if you get an abdominal aortic tracing. And also looking at the slope from the CW curve. Again, remember that the change in pressure is equal to 4 velocity squared. So in general, if this slope is greater, as in severe AI, the aortic pressure approaches the LV end diastolic pressure, this velocity will become less and the slope will become greater here. But one caveat is if you have conditions, coronary disease and others, that increase the LV end diastolic pressure, again, the slope also will become greater because the pressure difference will decrease, and you can erroneously call severe AI where you don't have it. Now, how prevalent are some of these conditions in free-living adults? And this was some work I did with Lucille Nicomo from the Mayo Clinic, really looking at a series of cohorts, ERIC, Cardia, and Cardiovascular Health Study. And again, nearly 12,000 adults. And the question was, what was the prevalence of various regurgitant and stenotic lesions? And notice that MR is the most prevalent. All of them increase with age. And again, the least prevalent was mitral stenosis again. And it's interesting that this is one of the most cited studies that they tell me about on a monthly basis, because I think because TAVR and MitraClips are increasing and people want a benchmark of how prevalent diseases are in the population. Now, to just take a little detour, this looks at the fen-phen story. And again, Connolly and co-workers at the Mayo Clinic identified patients who had taken anorexogen or diet drugs and required heart valve surgery, and found that the histopathological features were similar to carcinoid or ergotamine-induced valve disease. And this led to American Home Products, which manufactured some of the fen-phen derivatives or drugs, to ask us to be a core lab to look at how prevalent different regurgitant lesions were and stenotic lesions in patients who had recently taken either dexfenfluramine or fen-phen or unmatched controls. And again, they all underwent transthoracic echocardiograms. And what we found was at baseline, the prevalence rates of aortic regurg, mild or greater, were significantly increased in anorexogen users. Again, but there was no increase in prevalence of MR in these users. But interestingly, when we restudied them a year later, again, the controls, there were 8 controls who had aortic regurg, 7 decreased, 1 increased. On the dexfenfluramine, 23 decreased, 6 increased. And in the fen-phen, 15 decreased, 0 increased. And there are no known deaths or valve surgery. Now, but that did not prevent American Home Products for being sued and paying billions of dollars in settlement for diet injury cases. And despite manufacturers taking fen-phen off the market, patients were still calling, requesting prescriptions. And it sort of puts us as echocardiographers, we're in the middle of sort of an ethical conundrum. Who should decide the risk-benefit ratio when it's acceptable? And, you know, here's some possibilities, but I would just note that smoking is still legal and widely used in this country. Just a couple of slides about carotid IMT and using it in epidemiologic and clinical trials. Again, here to the left, between 2 and 3 is the intimomedial, and 4 and 5 intimomedial thickness. Here's a plaque. In the cardiovascular health study, we found that if you had the thickest IMTs in the highest quintile, your cumulative event-free rate was only 75% at the end of 7 years, whereas if you were in the lowest quintile, you were above 95% in cumulative event-free rate. Now, I just want to show you one story in terms of using this in a clinical trial, say for niacin. Now, we know that niacin has been shown to decrease LDL and increase HDL cholesterol. And there was a study called Arbiter-Haltz that in fact showed that the drug decreased subclinical disease as determined by carotid IMT in patients with CHD or CHD equivalent disease. Notice that niacin decreased the carotid IMT, whereas ezetimibe was associated with an increase for some reason. But another study published shortly thereafter looked at hard endpoints, MI, stroke, et cetera, in 1,700 patients, and in patients that, despite well-controlled LDL cholesterol, had low HDL and high triglycerides, and they were on simvastatin and ezetimibe. And although adding the extended release niacin increased HDL, it did not reduce MI, strokes, revascularization, ACS, compared to the patients in whom it was not added. So niacin was associated with decreased IMT, but no decrease in CVD events. So again, we have to be humble as we are measuring subclinical disease. And here are just some ways that subclinical disease may fail as a marker of hard endpoints. The absence of the surrogate from the causal pathway of the disease, although we did see it being decreased, but nonetheless, there may be multiple causal pathways, and the one that we detected is not the most important. There might be involvement of the surrogate in the pathway without the surrogate being influenced by the drug, although we saw here in our niacin case it was. And the effect of the drug may have disease-independent effects that may not influence the surrogate. So we have to keep this in mind. So the last section of this talk is I just want to spend a few slides on some areas that I think are now currently or in the near future are going to be important. And I would say all of them now, except perhaps the last, are being studied actively. Any of us know that that with the cardiac interventions, mushrooming, that you need an echocardiographer in the room for most of them to help guide whether it's a TAVR or perivalvular leak closure or mitral and tricuspid clip or mitral replacement. And the more traditionally SD-PFO closures, and in the EP lab or in the interventional lab for left atrial appendage closure, or again, thrombus vegetation extraction. Dr. Klappholtz here has a nice series of tricuspid valve vegetation extractions and arrhythmia ablation. And again, just a 3D slide of the mitral valve showing the different cusps, the anterior and posterior mitral valve, cusps 1, 2, and 3. And this slide given to me graciously by Linda Gellum, showing a mitral clip procedure that was clipping together 2 flail P2 segments. Again, just one slide to highlight a really important area that's only bound to grow. Now, another area that I found fascinating was the idea of ultrasound and microbubbles. And I'm going to go through about 4 different areas in which I think that this may be important, as shown on the slide here. Now, Dr. Sengupta mentioned that I was privileged to give the Edler lecture about 25 years ago. And I was, one of the slides I showed was suggesting that ultrasound could be used as therapy if we increase the mechanical index and we destroy these microbubbles, encapsulated gas microbubbles, that contain various vectors, whether VEGF or CMYC or an angiotensin II blocker, and we could perhaps improve vascularity, decrease LV internal dimension, or LV, increase LVEF. And I even said during that slide, tongue in cheek, that if business got bad for cardiologists, we could do a subcostal view and perhaps treat liver cancer by delivering vectors, imaging the liver, and exploding the microbubbles at the target site to release the vector. I don't think this has taken off very much. Thankfully, we have better targets now, but it was an idea. Now, another thing that ultrasound and microbubbles have been used for is for targeted molecular imaging. So this is the concept here. You inject molecularly targeted microbubbles in green in a vessel expressing molecular imaging targets that you want to target in red. And then you deliver a destroying pulse of high mechanical index, which destroys the unbound microbubbles. And the difference in the imaging signal acoustic intensity pre and post microbubble destruction corresponds to signal from the attached microbubbles. And this could be, for example, a marker of inflammation. Well, John Lindner in his lab has looked at this. This is in a mouse model where he was using p-selectin targeted microbubbles and doing brief LAD occlusions in mice, and then injecting them with these microbubbles 45 minutes after reperfusion. Notice the p-selectin here. And what he found was the myocardial contrast echo signal in the LAD region 45 minutes after ischemia reperfusion in a mouse model versus a controlled model was increased. And also in that ischemia reperfusion mouse in the anterior wall versus the posterior wall. So the question is, could this be used to target ischemia without myocardial infarction and maybe used in the ED and improve the speed and accuracy of risk assessment of patients presenting with symptoms suspicious of myocardial ischemia? Now, the spatial detection of recent but resolved myocardial ischemia without infarction could be done as shown with a commercially available microbubble for rapid evaluation of patients with chest pain. But we'll need human trials to determine whether this is specific for post-ischemic changes or may also be a marker of myocarditis or transplant and rejection. Now, in terms of sonothrombolysis, just a couple of slides to show that in this case, I thought this was fascinating. Matthias and co-workers studied 70 STEMI patients who underwent echo during continuous infusion of commercially available microbubbles and were randomized to intermittent high mechanical index or low mechanical index ultrasound when the microbubbles were in the risk area. And the high MI group received sonothrombolysis pre and post PCI. And they found remarkably no difference in door to balloon time between the two groups. I would have thought that this would have delayed the PCI, but presumably they were well trained in doing this. And they found that the angiographic recanalization prior to PCI was 50%, 58% in the high MI versus 9% in the low MI groups. And the recanalization in the high MI group was greater in the LAD than the other arteries. And the high MI group had a lower rate of adverse LV remodeling, so that this might be a useful technique. And finally, just a couple of words about echo and artificial intelligence. I mean, me talking about this in the presence of Dr. Sengupta, Yanamala, and the team is a little bit like, as they used to say, bringing coals to Newcastle. But this, I think, is a very important area where studies have shown that AI can guide echo performance. It can assist in image interpretation and automated measurements and in tissue characterization. And notice some of the articles that a small sample of what the group that Robert Wood has been involved in. And the goal is to combine this imaging, whether it's echo, CT, and MR, with EMR data to improve diagnosis, prognostication, and treatment. And the study I just saw over the weekend, I thought I would include that I thought was interesting, is you might even be able to use this to target and estimate coronary artery calcium. This study by Yuan in 2,800 patients looked at pairing TTEs and coronary CT calcium and used a video-based AI convolutional neural network to predict those who had 0 or high CAC scores, greater than 400 Agatston units, again, is suggested by guidelines. And it was very interesting that the TTE predicted CAC prognosticated differences in 1-year survival between the 0 and high CAC patients, similar to that predicted by CT CAC. So I think, and you can see these purple areas are what the ML algorithm targeted to come up with their score. And finally, I would say that this intrigues me, the idea of using wireless ultrasound sensors in genomics. And again, you could conceptualize a nanosensor, potentially including ultrasound crystals, could be implanted in individuals whose genome scans indicate a high risk for a cardiovascular event. And then, perhaps I think better than an Apple Watch, could detect abnormal high-risk cells in the blood or an abnormal ECG finding and send a signal, perhaps to that patient's smartphone or some other monitor, warning of an impending myocardial infarction or stroke. So I think that the future is very bright for echocardiography, and I wanted at this point to thank you for your attention.
Thank you very much, Jules, for a very stimulating and a very comprehensive coverage of the journey of echocardiography. So since I have you and you've seen the entire voyage of echocardiography, I want to ask you a very burning question. So one of your slides mentioned that close to about 10% of the population over the age of 75 is going to have valvular heart disease of some kind or the other. So we have a tsunami of structural heart diseases, and the question is, given the current scenarios where you have burnouts and workforce shortage, how do we perform a good echocardiography? And I worry that sometimes the pressure of trying to get the work done takes away on the quality, and there is always a pressure from trying to get patients out and getting inpatient echoes being done. And so much depends upon spending time. So how much time do you give for performing an echo? And what do you think in your mind should be the direction we should be moving towards?
Yeah, so I think now perhaps we spend, 45 minutes, something like that. But I'm relying on you, Partho, and AI to help us work with tools to enhance performance, to speed it up, and also to ensure an additional level of quality control so that the sonographers can spend less time and we can achieve some of the throughput that we need. The other thing, of course, is to train more sonographers through various incentives, whether it's through health systems or hospitals who, for example, help pay for their tuition to school, with them guaranteeing to spend a certain number of years in that health system. I think that's another way of approaching this, but I'm really hopeful that AI will help us with this.
All right, so I think the workflow and the efficiency using some of the smart tools will potentially help us. But how do you get a study when you cannot access the windows? For example, I mentioned to you that we do a lot of studies in the hospital patients, but they are lying on the beds in suboptimal ways and position, and it's very awkward to try and challenging to get the images. AI won't be able to do anything if the image quality is not going to be good, right? So
no. So right now, I mean, although we had this discussion before the lecture about using portable or even handheld portable machines, we don't do that in patients who we have COPD, who are obese, who are in our intensive care units. What we use it for more are folks who come in, say, on observation with this rule-out chest pain, and they're 30 years old. But I think, there's no substitute to getting a good image, whether we have to use microbubbles or some other technique. But I agree with you, if garbage in, garbage out. Yeah.
So do you do, in your location, do you get your inpatients into the echo lab? What's the percentage of that you move them? Because there are also challenges with transport and all that, then that lead to a suboptimal experience.
Yeah, so obviously one's in the intensive care unit and that we go to them. Others we do bring to the lab, but we've also had experienced similar problem with transport. And if we can a priori determine that they're the type of patient who is not obese, perhaps not COPD, we can scan the EMR and get a sense, or the fellow may know, then we can go to them and increase the throughput that way. But it's a constant case-by-case challenge currently.
And I was also interested in your slides when you were talking about the standardization of the two-dimensional measurements and the amount of variation that can come in when the LV is remodeling or becomes spherical, where your, guidelines mention, for example, as you are positioning, that you have to have the LV internal dimension at the tips of the mitral leaflet, but the LV may balloon out and your largest dimension is elsewhere.
Yeah.
I always see this continued debate, or at least not clarity in the guidelines. So what do you do in trying to at least get your dimensions?
Yeah.
Do you go for the largest area, or how do you do it?
Yeah. So what I do personally, and I'm not saying that all of our readers necessarily do the same, but what I try to teach the fellows is I try to go in that type of case, and I tried to show with the ventricular septal hypertrophy example, I try to go for a larger dimension, and I measure the thickness where I think it's most representative. Because again, we're taking a linear 2D dimension and trying to cube it with all the inherent errors, and we're not doing 3Ds in everybody. I mean, so we have to be at this point happy with that. But I'm hopeful that 3D will become more prevalent with its limitations. And again, I'm hopeful AI will help us a little bit in this area. But right now, I do not necessarily measure at the mitral leaflet tips.
So if you would take a good echocardiography study, and we do a lot of different measurements, but our consumers typically focus on a few measurements here or there. What do you think we should be really focusing on, ensuring that these are the measurements that the consumers are likely to use, providers are more interested in, and ensuring that the quality of that work in those measurements should be focused on? I mean, if we were to prioritize, or if a sonographer has to prioritize, what would be the few areas that you need to have good numbers?
So unless we get sort of an a priori, like we're looking for the change in the severity of valve regurg or that, I would say most of our consumers want to see an ejection fraction. And so we try to do biplane Simpsons. That's the best we have right now. Although, we all look at it to make sure that the edges have been drawn correctly in that. So, we don't check our brain because of the number. We look at that. But I think EF clearly is one of them. Some at least semi-quantitative estimate of valvular regurgitation. Wall motion abnormalities are certainly important. I think those are, and increasingly people want to know the PA systolic pressure in a lot of these patients. So we try to get a good TR jet, but again, as readers, I don't hesitate to say, and we have a code, could not get an adequate TR jet to measure this. So those are, by way of example, some of them. Obviously, if you see a tumor or a pericardial effusion or something, you'll call it out.
And Jules, you've been there from the times of M mode. Do you still use M mode, or you're mostly doing 2D and other? How do you get some of your measurements, linear measurements? Are you still using any of the M mode measurements?
So generally not. I mean, unless I really can't see it on 2D, and the M mode samples more times per second, so I can see an edge a little better. But I make the measurements off the 2D, for example, for thickness or dimension. Or that, and M mode is really just to see if I have a question and I can't see something, and I want to make sure I'm not getting the septal leaflet of the tricuspid valve in my septal measure in my ventricular septal measurement.
And the I was also intrigued by your there is a focus on subclinical disease. Do you think we are closer to any paradigm where we will be using any measurements in echocardiography as a endpoint for a clinical trial? Because you've been a clinical trialist. I know that in MRI, sometimes they are now starting to use MRI measurements as endpoints for clinical trials, particularly for remodeling therapies and things like that. What do you think could be reliable in echocardiography?
Well, again, if we're talking about the left ventricle, I think in general, we have to do a little bit better in terms of the reliability of the measurements. Especially if we're talking about, wanting to get 3D measurement, or I'm sorry, a measurement of mass or volume. I think we can use, 2D Simpsons in that if we're looking at large changes. But if we're looking at, relatively subtle changes, I think we need a little more help. And that's why I was sort of making a plea that if we can look at samples of patients who've had relatively contemporaneous MR and echo studies, and possibly, incorporate something from the EMR, that will make the echo study more reliable as an endpoint for, say, a clinical trial.
Very nice. I think it's been a great sets of information that you've provided, Jules, and we are really looking forward to collaborating with you. And I think you're right, as we are starting to use some of this new technology, I think there will be more work on implementation science, because I think we all talk about technology, but I think it's when the rubber meets the road and you understand some of the difficulties that one can experience. I think AI is not necessarily always panacea, because there are challenges, and we need to be aware of some of the challenges also. So we are in the process of trying to write some grants together. Hopefully in the near future, we'll have a chance to work together.
Absolutely.
Thank you very much, and very nice of you to spend time with us tonight, and look forward to having you back again in the near future.
Thank you so much, Dr.
Thank you very much, Jules.
Thank you.
Yeah, thank you. Thank you all.